Hey everyone, welcome to Clinical Unfiltered with Dr. Sausha, that's me. And today we're going to get unfiltered with just me, Dr. Sausha. So give me your hearts, your minds, and your teeth, and let's get unfiltered about a topic that I am very passionate about and I speak about a lot. So it's probably one of the most common topics I actually get sent out to lecture about, which is in regards to grafting. But I want to focus in on one topic. It's literally like the only science I ever drop, or at least focus on when I lecture about bone grafting. And I think it's so critical because it really explains why your bone grafts do well or why your bone grafts suck. I really think it helps encompass every thought process you need to get a successful bone graft is summarized by this article. And it's a group led by Homely Wang. They devised this acronym called the PASS principles, or PASS principles. And basically, if you follow this acronym to the T, you will have your near perfect bone grafting experience. And if for some reason your bone graft sucks, now granted, there's always patient factors that play a role too, but if your bone graft sucks and you did not follow one of these principles, you will have less of an ideal bone graft, and that explains why your bone grafts suck. So I really like to focus in, summarize this PASS principle so it really gets ingrained to you. When I teach, I want every student knowing at least the PASS principles. And then with that, I will follow up and show and try to verbally describe a case and also share slides. So if you have the ability to actually watch this episode, you'll be able to see this one crazy case that applies the PASS principles. And because I applied them so closely, got the most ideal results you can possibly get. So, PASS principle. Again, in regards to bone grafting, or honestly, any tissue grafting, period. And according to this article, I'm going to bring it up and I'm going to share it. So again, I'm going to describe it verbally, but you can look and possibly see the slides themselves on your phone or tablet or computer, wherever you're actually looking. There we go. Okay, so the PASS principles, P stands for primary wound coverage or tension-free wound closure. That's what the P stands for, primary wound coverage. A is angiogenesis, adequate blood supply, intramarrow penetration, so getting good blood supply. Now, the two S's, so honestly, they're like same, but different. They're very similar, but there is some major differences in them. One is space creation maintenance, and the big part to this S is cell exclusion of unwanted cells. So creating a space that excludes unwanted cells. Then the second S is stability of the wound or implant or any graft, stability of the graft, for example. So I'm going to break down each one. Okay, so P, primary wound coverage. And I will tell you, this is the one that to a certain extent we all flirt with, and it's the most okay. Because, so what happens when you have like a socket, for example? You have an open wound, a secondary intention wound. Now, the epithelial cells will kind of start migrating into this wound, and technically some fibroblasts and osteoprogenitor cells or cells of that line will start moving into that same space. It's a race between the two. And so when the epithelial cells are super fast, the bone cells, they're slow. So in essence, when that wound is trying to close, that socket is trying to close, your epithelial cells, which create more just gum tissue, fills in much quicker than your bone cells, and hence you'll get more gum tissue or some kind of collapse of the amount of bone if you leave an open socket, as compared to if you were to close the gum tissue over the socket. And the reason being is epithelial cells, when they touch each other, there's something called contact inhibition. So they will hit each other and stop. They'll stop moving and they'll stop migrating further. And so that's why primary wound coverage helps bone cells heal, because if you get the two ends of a wound to touch each other, stuff can brew underneath the gum tissue. So in a socket scenario, again, you get the two edges of the socket to touch each other, the two edges of the gum tissue, and it won't mess with your socket underneath. That gives time for your bone cells to move in, migrate in, and generate bone. It gives it plenty of time. Basically, the gum cells are like, you know what? I'm going to step back. Bone cells, do your thing. Now, when you do that, when you do stretch the gum tissue, you end up kind of creating sometimes what we call a mucogingival defect. or you lose some gum tissue in the process that you otherwise would have gained if you left the socket open to heal. So there is an argument here that you can do some form of grafting without getting the socket to close all the way. And we do this a lot. And this is why we're okay with it, because what ends up happening is, yes, you will lose a little bit of bone potential by leaving it in as an open socket. But the gum tissue can migrate over that area and form new gum tissue. And often, the type of tissue around a socket is keratinized tissue. So often you're gaining like that good quality of gum tissue, not mucosa, but like good, thick, keratinized tissue. So it's almost like a way of getting like a free gum graft in the process as well. So that's why we flirt with this one. I will tell you, in general, it depends on how much bone I need. Again, if you stick to the past principles and you get primary wound coverage, you're going to get more ideal bone grafting results. So just understand that. How critical is the amount of bone you're trying to gain? Have they lost lots of bone and you need to get a lot back to make this work? Then yeah, you're probably going to need to get primary wound coverage. Think, okay, it's never black and white. It's always the gray. So this is where you got to use your critical thinking skill. Do you need more gum tissue? Is it a number 8 or 9 and you want extra keratinized tissue? If you do, leave the socket open. Let it granulate in, because the epithelial cells will fill that space on the top of the socket and give you more keratinized tissue. So it's worth leaving it open in those scenarios. And sometimes on patients who have really thin biotypes and you know it's going to be hard to get gum tissue and you don't want to do a gum graft, then purposely leave it open. Maybe place a membrane over the bone graft so it's protected a little bit more. And that way you can kind of generate still some good quality bone, but give some room for epithelial cells to grow over. But if you got a blown out socket and you need a lot of bone, then you might need to be considering getting primary wound coverage to get ideal bone graft results. So that's PEEP. That's primary wound coverage. And that's a little bit into why we flirt with it, why we don't. Angiogenesis. Oh, the A is blocked out on this one. Angiogenesis. And so for A, angiogenesis, I will tell you, it's blood supply. It's how much is it bleeding into your socket or your grafting site? How much blood supply are you getting? I will tell you in general, if you're doing a bone graft in the upper maxilla, anterior maxilla, honestly posterior, anywhere in the upper, you're probably going to have more marrowous bone and you're going to have more blood into the area. It's easier to get stuff to bleed on the upper than it is on a very thick cortical plate on the lower. And there'll be times where you'll take out a tooth and you'll look in the socket and it'll be bone dry. And you'll just let the patient, maybe you jump to another patient to do a quick new patient consult. You come back in the room and the socket's still bone dry. That is an issue because the blood supply or a stabilized blood clot actually starts the whole freaking process. A stable blood clot is super critical to regenerating bone. It starts a cascade, which often is blood clot forms, then that signals cleaning cells to come in to clean up the site. And then after that, after the cleanup's done, then the kind of the buildup or the bone building cells come in to now suddenly start growing tissue and bone. And you need for that process, and then eventually you have new bone. And for that process to start, it starts with a stable blood clot, which can be hard to stabilize if you really think how soft and mushy it is. If you've ever seen PRF, it's a unique substance that needs some form of if there's intact walls, you'll probably get some stability of that blood clot, but you need a good blood clot. That requires blood. So on the lower, for example, if you're doing a ridge augmentation and you have a thick cortical plate, you're going to open up a flap and you're just going to see white bone staring off-white, beige, whatever the hell bone color is, staring right back at you. You need to poke holes through that bone to generate some bleeding into the area. So in ridge augmentations, we're always poking holes on the lower mandible, especially on little defects, like little collapsed horizontal defects, vertical defect, whatever. Maxilla, again, in this picture I'm showing you, there's a 8 and 9, and you can actually physically see what looks like punctured holes, but it's just marrow spaces in the socket. And this blood, as the socket's so bloody that I can't even stop the blood to take a picture. That's honestly a good thing sometimes, because that's going to help provide lots of blood supply for your bone graft. So a site that's bleeding like crazy, it's not technically that bad. If you can get it controlled enough to finish the procedure, you at least know you've got good angiogenesis potential. Angiogenesis is just a fancy term for new new blood formation. And basically, the more blood, the more likely you're able to generate better growth in the region. So blood is super critical. So in a dry bone socket, like your dry, it's not a dry. I'm not talking about dry socket. I'm talking a socket that's got no blood supply to it. Poke holes in it, scratch the gum tissue, get blood to flop in, or learn how to do platelet-rich fibrin. Learn how to do blood concentrate materials. You draw blood from other spots of the body, but then put into areas that need more blood supply. It's a very useful tool. We'll do an episode on that again. We've done that in the past. So I'll bring back my PRF friend to talk more about PRF and the unique techniques that are revolving around the use of blood concentrate material. Let's move on to S. So space maintenance and cell selectivity. We're on to the S. Cell selectivity here is super critical because, again, remember I told you those epithelial cells are super quick versus the bone cells being, the osteoblast, the osteoprogenitor cells being so much slower. You need to slow the epithelial cells down or keep them out even better. Let them run into each other and separate them out from the region you want, bone. So again, maintain the space for just the cells you want. That's what this S is trying to tell you. And I always give for a socket, I always give the analogy of a solo cup. An intact socket is literally got one potential door to get in and out with epithelial cells, which is the top. The lid's open at the top. So the only way a fly can get in or an epithelial cell can get in is from the top of the solo cup. The only way to get it for it to get into your cheap beer is from that top. Now, if you have a broken cup or a mug that's been chipped in different spots, now there's new ways for contaminants or epithelial cells to get inside your cup or your socket. And those cells can come in there and disrupt the space which you're trying to maintain for your bone cells. And there's ways, if you have like a broken socket, to help protect that space. And that's where membranes are a huge component in grafting. If you do tons of socket grafting and never use a membrane, you are getting crappier bone results, and you know it. You know it. Otherwise, you're lying to yourself, or you're the luckiest person in the world. That doesn't happen. If you have a really broken down socket, I'm showing in this top right picture like an 8-9 with zero facial plate. If you do not apply a membrane here, you have a whole facial plate gone, which means that space is not going to be able to be protected for the bone cells to take their time and build. Other cells are going to come in and move in and eat into that bone graft space, and you're going to have less than ideal bone graft quality and quantity. So that's where space maintenance comes into play. Stability is probably, it's the easiest one to explain. I always tell people when you break an arm, they put you in a cast. Because especially for bone cells, and honestly any tissue, for it to grow into the tissue that it's meant to grow into, it needs to not be moved around. So if you break an arm and you don't wear a cast, your whatever joint that broke is going to turn into like fibrous tissue. Same thing with a socket. If it's not a stable wound and it rocks around, you're going to get less than ideal bone graft. You're going to get granulated bone, or you're going to lose bone dimension. And believe it or not, in the mouth, that happens a lot. And again, the whole solo cup analogy, an intact cup, you could pour water, you can pour yogurt in it, and guess what? It can stay pretty stable to a certain extent. And again, this is where patient factor comes into play. If you got a patient who's like next day doing like yoga, Pilates while doing pickleball, or doing pickleball with like, goats on the field or something, and something happens and hits that solo cup or hits their face, or they're jostling it around, that stability drops. So sometimes you have to like purposely stabilize the bone graft or the soft tissue graft. Sometimes you have to do something extra to stabilize it. Now, that's for an intact socket. If the sockets are really broken down and you just shove like particulate bone and then close a flap and don't do a membrane, don't do special sutures, don't do tacks, don't do anything to stabilize that bone graft, the patients will eat, chew, function, everything that they could possibly think they could do in their mouth. They're going to do just naturally living their lives. And that's going to disrupt the stability of the wound. They've done some unique studies where they've like done ridge augmentations where they opened up a flap, added bone on pig jaws, and closed them up, and didn't stabilize the bone graft with any fancy sutures or tacks. They just kind of put some interrupted sutures and called it a day, and then walked away and took the pig jaw like 10 feet over to the cone beam machine and took a cone beam. And within that movement, about 50% of the graft moves. It moves. Grafts move around. Again, especially if a patient's functioning. So stabilizing that graft is super critical if you're in an area that is not very stable. Again, broken down facial plate on 8 and 9, that's not a very stable wound. You're going to notice that the bone will want to drift around or move around right out the gate. Even as you're suturing, the bone's moving around. In those instances, sometimes you need to tack a membrane into place and wiggle the tissue around to see that the graft isn't moving despite the gum tissues moving. Another way is to do something we call periosteal sling sutures, where essentially you dissect the internal periosteum. And again, I'll do a whole episode on just advanced grafting techniques. But you need to utilize advanced techniques to then stabilize or suture the graft in place beyond just closing a flap, to be able to create stability in your grafts. When we do soft tissue grafts, we do the same thing. We suture like crazy. As a periodontist, we suture these soft tissue grafts really tight and actually like stretch and mobilize the lip around this to make sure that we got stability and we're not going to get a lot of mobility of the gum tissue graft, because if you do, the gum tissue grafts fail to heal. Luckily, gum tissues only take a week, but bone takes longer, so you need to do really something extra to stabilize it. But if you have an intact socket, you're probably fine. A lot of that, like a crisscross figure 8 suture on top, maybe a membrane, maybe none, that might be enough to stabilize the graft enough. Again, if it's an intact socket or an intact solo cup. But if it's not, you really got to consider other techniques. One trick I do sometimes is I will watch the blood clot fill my defect. So even if I have a flap open or not a flap open, I'll watch what the blood clot's doing. If I notice that a blood clot's forming and then almost like slipping away and parts of the bone are exposed, but most of it's covered under a blood clot. Now, I'm not talking about it just bleeding into the site. I'm talking about actual formation of a blood clot or early formation of a blood clot, which sometimes can happen, within minutes. And so I will watch how that settles. And if I see exposed bone, that'll often give you a rough idea of how much like regeneration potential you have with the defect you have. Again, an intact socket, the blood clot will stabilize in most of the socket. And so, yeah, you probably regenerate most of that socket. But if it's an open defect or you have lots of walls missing, that clot does tend to slide. And so will your graft. So those are the four. That's the PASS principle. PASS. Primary wound coverage, angiogenesis, space maintenance and cell exclusion, and stability. Those are the four principles that if you put them together, if you combine all those, you can do anything. When you're in a rut, you're stuck in a grafting scenario, you're trying to figure out what the heck do I need to do to get the best result, think back to the PASS principle. When you have a shitty result, step back. Be like, what? Which one of these steps did I screw up? Which one of them did I not? Which one did I miss? Which one did I miss the mark on that caused this bone graft to fail? And you will often be able to boil it down. You know what? You're like, hey, you know what? I didn't get primary wound coverage, so this is probably what I should have expected. Primary wound coverage without any kind of membrane. I'll tell you there, again, when I get into advanced grafting, there's some benefits to a membrane in certain scenarios. And then often, I'll tell you the one that's the most often, I think, given up on is that you have a broken down socket and you don't know it. And then you don't do a good job of space maintenance and stability. That's probably the most common, is that people don't do a good enough job assessing their sockets to figure out if they need a membrane or not. And those are the cases that go bad. That's probably the most common problem. So look within your soul. Think about the grafts. You're like, that was weird. That was a lot of extra granulation tissue and particles. That's probably what you screwed up on. And that's okay. That's okay to, at least if you know, you can isolate out those problems, learn better, and do better. Now let's look at this extreme case. Okay, I told you I was going to show a case. This is a young patient. I think she was 17 at the time. And she went to have an impacted canine removed. And it went horribly. She healed terribly. This is like the immediate post-op from having her impacted canine removed. And if you're not looking at this, her teeth are wired together right now because they're all mobile. And there's no facial bone. And there's actually no palatal bone around I believe it's number 9 and 10. And I actually got this picture sent to me by the oral surgeon who took out the canine to say, hey, and there's no soft tissue. There's nothing except for like what looks like chia seeds stuck in the site. And it is a massive vertical defect if that I could gum graft this. And I will tell you, this is such a bad defect that like 9 and 10 need to be extracted pretty much as soon as possible. And that was my like personal response. I was like, remove those teeth. And I will tell you, after the extraction or after it healed, they didn't listen right away because they wanted to see how it would resolve. And it resolved terribly. And 9 and 10, if you're now looking at the screen, you're seeing massive vertical defect. You're pretty much seeing the whole root of 9 and 10 come out of the bone and soft tissue. And this might actually trigger you to stop and look at your phone or computer to look at the actual podcast because it is a gnarly defect. Again, 17-year-old. So the teeth come out and we're stuck with a vertical defect that's pretty much to the floor of the nose at 9 and 10. And number 11 starting to fall apart too. Now you can notice the hygiene's terrible on this patient. You know what actually though, this was intriguing as well. This patient was found to be diabetic after the healing process of this procedure. The oral surgeon was smart enough to know that this is way beyond normal healing. Granted, though, the surgery didn't go that well, but this was way beyond normal healing. So they looked into it, tested her blood sugar. She was hugely diabetic. She was obese. So she lost tons of weight and I think over like 70 pounds of weight and got her blood sugar under control. So she was feeling better. At this stage, though, I was like, with this massive of a defect, with her age, she had just turned 18. I was like, let's put gum tissue here and send her to a prosthodontist. So I finally jump in and I do a soft tissue graft. And it heals phenomenally. She gains so much keratinized tissue. So she can heal well now. But again, number 11 is kind of crap in the bed. And the mom, the whole time, I mean, the oral surgeon that worked with her is phenomenal. Great communicator. And the mom still loves the oral surgeon and us and everything we're doing and still wants us to do the implant surgery. And it's a long, funny story, but we eventually decide, okay, we're going to try with zero promises because that vertical defect of bone is huge. Now, again, I know my past principles, so I start applying them. I start applying them to this case. Okay, so we open up this case. And again, vertical defect, 18 years old, female, bone loss to the floor of the nose from pretty much 9, 10, and 11 still has some bone. So I've got a peak of bone at 11 that I can work with. And with these kind of defects, I will tell you, if you try to hold on to one of the teeth that's losing a lot of bone, you will limit how much bone regeneration you can get in these kind of scenarios. Because you need 2 peaks of bone on either side to be able to vertically grow bone. So, again, we're in the maxilla, so blood supply isn't like a terrible issue here. We got lots of blood supply. The incisive nerve canal is actually bundled in with the flap. You can actually see like some parts of the bundle of the incisive nerve canal in the defect. It's such a huge defect that crosses pretty much 9 to 8. So blood supply is no problem here. But what we're going to have is a hard time creating a stable bone graft. And to do that, because it's such a big vertical defect, there's just zero bone or walls anywhere. It's negative walls. If I was to put bone there, it would just persistently move around, flop around. And if I use nothing like sturdy, even like just particulate and a membrane, it'll move around constantly. And I need lots of time for this to heal. I mean, this needs almost like a year-long of healing to really turn into bone. So in this instance, to help with stability, I use the titanium mesh. And I actually specifically use a custom-made titanium mesh from a company, I think it's Reos is the name of the company, Reoss. You send them a cone beam. They generate a mock-up of what the mesh will look like, and then they send it to you. You approve it, gets sent to you. It's pretty much perfectly shaped to your defect, and it's got little prongs on it, so you literally just plop it into place. Super easy to use. Super easy. It's my favorite custom titanium mesh to use. Otherwise, there are other like titanium meshes that you can use for these kind of defects, but for ease of use, this is the best one, but this is the most expensive. I want to say this is like $300 or $400, maybe more, for just the mesh itself. And I fixated this with one screw. It had multiple holes. I think it had like 3 or 4 holes that I could fixate it with. But after one fixate, honestly, just plopping it into place, it had a lot of stability. But just to keep it there, I put one screw in there, and man, that thing would not move. I mean, I whacked it with my mirror. It didn't move an inch. I put autogenous bone mixed with allograft particulate bone inside this cage, inside this titanium cage. But Again, now we've got a stable wound. We got plenty of angiogenesis. Okay, so we've got 2 of those checked off. We don't have cell selectivity for this space. Okay, so the space won't be maintained with just bone cells at this point. There's a chance that epithelial cells will move in. So I layered a collagen membrane over it. I specifically, in this scenario, used a pericardial collagen membrane. So it's got good tensile strength and it's easy to manipulate. Actually, uniquely in this scenario, it's just a funny story the way this case kind of came up. I didn't think I was actually doing the surgery. I thought my oral surgery friend was doing the surgery and found out last minute that I'm the one actually, while the patient's sedated, that I'm the one stepping in to do the actual physical surgery. And we didn't have many membranes on hand that were big enough. And I happened to have one sample of this new membrane at the time called Osix Agile. Super cool membrane. Probably my favorite collagen membrane on the market. One of the big features about it, it's cross-linked collagen. So they add these cross linkages to the collagen compared to a native collagen membrane, which kind of breaks down relatively quickly. This cross linkage makes it take longer to break down, and because of that, it lasts longer and provides a barrier and cell selectivity barrier against the epithelial cells much longer. And again, I need tons of time for this thing to cook. So this was my favorite membrane to even have in this kind of scenario. And I even tacked the membrane down so the membrane wouldn't move that much either. So I did what we call a periosteal sling suture. Now the hardest part is, since we had such a big defect, to add all this other material and then be able to close over it is tough. And also considering how much scar tissue she had developed from the whole process. I'm talking losing those 2 teeth, having the canine removed, losing those 2 teeth, having a gum graft in the area, so much scar tissue. So I got to stretch this leathery tissue over all this payload I added underneath the gum tissue. I mean, imagine going to Christmas. Imagine going to Christmas. You got a suitcase. It's full of all your stuff you need to go on Christmas vacation. And then you go to Christmas and they give you tons of presents that you now have to put back into your suitcase on top of all the stuff you already have. That's the issue we're dealing with here. Gum tissue is settled, so we have to open up the gum tissues and add all this extra material and stretch over it. That's where advanced advanced techniques to create flap advancement come into a huge role in these kind of cases, because I've got stability, I've got cell selectivity and space maintenance, I've got angiogenesis, now I need primary wound coverage. Super critical for that piece. I have a lot of bone that needs to heal for a lot of time. I've gained plenty of gum tissue from gum graft, so I don't need that anymore. I need primary wound coverage. So to do that, I have to score the tissue internally, twice. I think I created 2 periosteal release incisions separately to be able to get primary wound coverage over this thing. It was tough. That was probably the hardest part of this procedure. But I was. The great thing is she was able to maintain that primary wound coverage. The issue with titanium or non-resorbable components that are used for grafting is that you have to take them out at some point. And if it happens while the healing process is going on, you're going to start hampering some of your potential results. So I'm hoping that she maintains primary closure the whole time. And she does. 3 months later, the ridge is so, I've advanced the ridge so much that the gum tissue is midway up the neighboring teeth in the edentulous site, which is essentially at this point is 9, 10, and 11. So that space is higher than the neighboring teeth, which I want. You want excess of tissue in these areas. 8 months comes by, we take a cone beam, and what looks like tons of bone developing in that area. I wanted her to wait a year. So we did actually go into the surgery at about 1 year with a surgical guide. I did open up. So when I opened up, I will tell you there was some bone or osteoid growing over the actual mesh. And I had people, whenever I present this case, be like, oh my God, you're going to have to dig out the mesh if this works well. And I'm like, yeah, that would be awesome. I would be stoked to take out this titanium mesh. I want to have that problem. That means I gained a lot of new bone on this patient. And that's what I had to do. I had to drill out some parts of bone to be able to get this mesh off. Again, the design of this mesh is so superior that you don't have to cut it all out. There's a few points, easy break points, that if you cut through, you can remove the rest of it pretty smoothly. And once I take it out, I actually am looking at a lot of new bone formation. but it's still not got that final texture of like native bone, even almost a year out from doing from the initial grafting procedure. So I use a guide to be able to get the implant in the exact spots I want, because again, that texture of bone is different than native bone. And if you were to drill into it, you'll feel variation. There's a way to actually drift off course in these kind of scenarios when you have a lot of grafted bone. So a static guide is super useful for these kind of vertical ridge augmentation results. And again, I want this bone to keep healing. I just rip the blood supply in the periosteum off the bone in the process of it maturing. So to protect it, to continue protecting it, I actually layered another collagen membrane. Again, a cross-linked collagen membrane. This one's the Ossix Plus membrane. It's slightly different than the pericardial membrane, the Ossix Agile, but it is a cross-linked collagen membrane, not a native collagen membrane. It's cross-linked with ribose, which is a tissue-friendly way, it's essentially sugar, to link it together. That, again, just provides longevity and protection. It continues to allow the bone cells to keep cooking. And so I place my implants, place my membrane, and close it up again. Let her heal. I think we let her heal for like 4 more months. Then we went to go uncover the implants, and the bone this time, I couldn't see the cover screw. The bone was rock hard. I'm talking rock hard on top of the implant. And so I had to drill away and I'm bumping into the cover screws. Again, I'm happy to do it because that means I gained so much tissue. And I had so much gum tissue, so much bone tissue. I was able to place the healing abutments and then send the patient off to start getting her provisionalization done. And brought her from this crazy defect to some potential hope of having teeth in that region that are fixated in there that don't touch her neighboring teeth. And was able to really restore her potential smile with dental implants. And again, just following the past principle. And I always tell patients, I always tell doctors when I'm teaching them the grafting courses, is that you're a skip away from being able to do these kind of crazy bone grafts. It's not that hard once you understand the principles and you practice the simple techniques. For example, flap advancement, like split scoring the periosteum to advance the flap, or doing fixation sutures. If you've done those things multiple times in other cases that aren't as dire, maybe just horizontal ridge defects, not vertical ridge defects, you're just a step away from being able to then do the vertical techniques. There are so many different ways to graft. I often like to just teach 1 or 2 that work so well for me. So you can focus on 1 or 2 and master those rather than worry about a giant decision tree, a million different techniques. The people who teach their technique, they do that technique themselves a lot. They don't do all the techniques all the time. So if you sit there and go into CE courses and try to learn all the crazy vertical ridge augmentation techniques, you're probably going to go crazy and end up not doing any of them. So really, look out there, see what techniques have worked in other clinicians' hands, see what might work in yours. What to me is always the easiest is the ones I want to do, or the ones that are most efficient, and learn how to apply that technique. And go start with the baby steps and grow yourself to do the advanced step. Again, if you want another resource on how to apply the past principles, I actually have a grafting course that I do here in Tampa, St. Pete specifically. So if you follow me at Perio Hero, I often post about it through an organization or group that I call Dental Show and Tell. So it's a little bit of self, promotion here, I guess, technically. But I just want to give you guys another potential resource to be able to do some grafting courses and learn more about how to grow to this level. Right now, I'm currently showing early stage grafting techniques, what I'd consider how to graft 99% of defects. I consider this the 1%. And if you can nail those early techniques, you can then learn and grow easily at that point to do a more difficult ridge augmentation. Again, thank you guys so much for hanging out with me and listening and going through this crazy case. And again, if you take anything away from this, the past principles. Like, share, comment, tell your grandma about the past principles so she can come, share, comment, and just give us feedback on if this was helpful for you, if it wasn't, what other types of procedures you'd like to hear about or techniques. And I'll try to either do it myself or bring in an expert. Again, thank you guys so much for getting Unfiltered.